Thank you, Mr. Chairman. I thank the organizers for the kind invitation. I have no declaration, only to say that I have received catheters from Maquet to perform a sleep study and a weaning study. This is what I'm going to tell, something about sleep in the ICU. What are the factors affecting sleep quality? Do we need to care about sleep? Conventional mechanical ventilation and sleep. Mechanical ventilation with NAVA and sleep. Patient ventilator asynchrony and the potential added value of NAVA. And some sleep study in the ICU and a conclusion. So, we know about sleep in ICU patients that sleep architecture is quite disturbed, as you can see in a normal population compared to an ICU population.
You might have putting your hands over it.
As you can see, there is a decrease in stage 3 and REM sleep, which stage 3 and 4 is also called slow wave sleep and restorative sleep, and an increase in stage 1 and stage 2. This is a hypnogram from one of our patients, and what you can see is that sleep distribution and the rhythm, the circadian rhythm of the sleep, is quite disturbed. Total sleep time may be quite normal, but it's said that, or it's demonstrated in studies, that almost half of the sleep occurs during daytime. And the last thing is that there is quite a lot of sleep fragmentation. That means there are arousals and awakenings. And as you can see in this slide, you see that here there is some disturbance on the EEG signal, which is caused by temporal relation by noise. And this is happening about 10 or 10 times per hour for arousals and 10 or 11 times per hour for awakenings, which means that almost 20 times per hour you are aroused or awakened. Do we need to care about sleep in ICU patients? Well, it's known that sleep has immunological effects on several systems, hormonal effects, but also a direct effect on the lungs and the pulmonary mechanics. There can be an effect on hypoxic and hypercapnic responses and an effect on the respiratory muscle. But these are only studies in healthy volunteers. There is also an effect on on psychological and neurobehavioral factors. There is a close relationship with delirium. This is something I took from a review from Dr. Winehouse. And this is important because delirium and sleep deprivation share many common factors in the pathophysiology. And we know from delirium that it's associated with increased duration of mechanical ventilation, increased ICU stay, increased cost, loss of cognitive impairment, and increased mortality. Also from sleep deprivation, we know that almost 50% of the patients in ICU experience nightmares. And on the long term, there are quite some patients who keep sleep disturbance after discharge with negative impact on quality of life. And you see that, well, the ICU is quite a hostile environment. There are a lot of factors that are affecting sleep. Noise is a common factor that is put up very early, but in studies it has been shown that it's responsible for about 20% of arousals and awakenings, and so there are a lot of other factors that are important too. And well, you can see them here. Don't think that the TV is always playing for the patient. So, what is the effect of being ventilated? Well, in this slide I took from this paper, you can see that comparing spontaneous with mechanical ventilation, there is already some alteration in sleep architecture. When you compare ventilatory modes, this is pressure support with PIV. This is the absolute mean difference between pressure support and PIV. Well, there is quite a difference in sleep architecture in favor of PIV in this study. This is another study where they compared assisted control with pressure support, where they saw also an effect. And what they did too was that they added some dead space in the pressure in a third arm. And what you can see is that the number of awakenings and the sleep efficiency are influenced. It's like, well, decreasing pressure support and decreasing the risk of over-assistance. At my knowledge, there is only one published very fine study with NAVA and sleep from a group from Montreal with 14 patients, which is quite a big study in sleep medicine. And you can see that they very nicely looked at the sleep stages, and they compared pressure support with NAVA. It was, like most sleep studies, a crossover study, and they did 4 hours NAVA, 4 hours pressure support, 4 hours NAVA, 4 hours pressure support in a randomized manner where the starting ventilatory mode was randomized. And between modes there was, I think, a 2-hour washout period. And you see that here with NAVA, you see that there is, compared to pressure support, lower time in stage 1 and stage 2, and a higher time in stage 3 and 4, which is called restorative sleep, and more REM sleep too. And these are the numbers. They're all p-values which are quite very significant. There is a much lower fragmentation index and a much higher sleep efficacy in this study. This is from our patients. We put here total sleep time, and you can see that, well, in most patients we had quite an effect. The problem we faced was that it was quite difficult in some patients, in critically ill patients, to differentiate between sleep stages in these patients. The sleep laboratory told us that, well, probably some of our patients were having some metabolic encephalopathy, and it was not, well, quite simple to differentiate. And how is it affecting sleep? Well, probably, as the previous speaker already explained, there is some effect of patient ventilatory asynchrony. This is done in non-invasive ventilation. Well, you see that there is quite an effect in REM sleep and ineffective breaths. How can this occur? Well, for instance, these are ineffective breaths, and you see with the temporal relationship that there should be an arousal, and it can affect sleep. This is another example from a patient with central apnea, and it's followed by an arousal. It can be caused by the setting of the ventilator, namely over-assistance. This is another study from Dr. Bosma, where you can see that the number of patient ventilator asynchronous is quite well correlated with the number of arousals, and this is in PIV and pressure support from the previous, the other slide I showed you before from the same study. So what might be the potential added value of NAVA? Well, studies so far published suggest that a more physiological ventilator mode and or physiological ventilator setting may benefit sleep quality. And at least in my mind, NAVA is a proportional and synchronous ventilatory assist with preservation of the variable breathing pattern integrated in the neuroventilatory coupling mechanism. So this means that maybe ventilator assistance during wakefulness may not be appropriate during sleep. And you can avoid over-assistance, you can avoid central sleep apnea and influence your sleep efficiency. This was also looked at in the study from Montreal, where you see that in NAVA and in pressure support, they looked at asynchronies. And you see that here in stage 3 and 4, compared to NAVA, asynchrony is quite well preserved compared to stage 1. Also, expiratory time asynchrony is very different. So, Sleep studies in the ICU, well, in real ICU patients, I think there must be about 25 studies. Mostly are observational sleep architecture studies. Some are, well, also a lot of these are pointed at looking which is the environmental influence, and mostly noise and light. There is one interventional study with sedation, and there are a few interventional studies with mechanical ventilation, and the one Montreal study I showed you. The number of patients is quite low. Having a study of 20 patients in a sleep study is quite a big study. It's an enormous amount of work with very heterogeneous populations, and the durations are also very variable, from a couple of hours during the night to 3 or 4 nights in one study. And this is what we think about it. We don't know if the criteria of Richthofen and Kales or the American Sleep Disorders Association criteria are applicable to ICU patients. So my conclusion is that the ventilatory mode and the ventilator setting may play an important role in sleep quality in ICU patients. It seems that a more physiological ventilator mode or a more physiological ventilator setting may improve sleep quality. And NAVA may certainly have an added value to improve that sleep quality by means of its patient-ventilator synchrony. Sleep studies in ICU, however, are a challenging task, being subject to many confounding factors that make interpretation and comparison a very difficult job. And not one study mentions non-classifiable sleep, although in my mind it seems reasonable to assume that ICU patients may have EEG patterns that are quite different from ambulatory patients. Thank you.
Thank you very much. Is there any short question on this topic? Christophe?
Thank you. So, when you said, like, I'm just reflecting back on Jean-Christophe's presentation and the entrainment factor, because as you say, like, the drive and everything changes very much from awake to sleep. Mm-hmm. Is there, either of you have any comments on this? The factor, did you ever look upon sleep stages in your patients when you study entrainment, or?
No, we just look at the Ramsay score to characterize sedation. It was an intermediate score. But I think it will be interesting to have more recording with a sleep recording, I think.
We looked at sleep asynchronies, but in fact we never asked ourselves what is the mean EDI during sleep, and it's a simple question, but I don't know the number. No. I cannot say it. I will look at it. I will mail it.